Very good evening to everybody. It's a great pleasure to have a program for all the leading physicians, general practitioners, and surgeons. On behalf of Sun Pharma, I would like to welcome everyone. And I take this opportunity to have two Aruns, Dr. A.C. Arun as well as Dr. N. Arun, who are legends in their own specialty practice, and young energetic legends are available with us. And I request everyone to participate, and whatever is a question you can ideally ask them. And without taking much of your time, I just share Sun Pharma has been a part of gastroenterology for decades. Sun Pharma, even in the pandemic period, we have been having good number of academic programs, and it will continue to happen. Whether it's a virtual or physical program, we will continue to have it. We will be a part of gastroenterology. And Sun Pharma has got today 40 divisions. Every division has got 1 or 2 meetings every week. So it's a matter of pride for all of us to serve you better. And without taking much of the time, I just hand over the session to Dr. A.C. Arun. He's basically from Madurai. In fact, he's attached to Velamal Medical College as assistant professor. And we do have Dr. N. Arun, who is a speaker, and he is attached to Chennai Kilpauk Medical College, that is a digestive disease department, which is affiliated to KMCH. So with this, I just hand over the session to Dr. A.C. Arun, who is a moderator. Please, sir.
So very good evening to one and all. So I would like to thank the organizers for organizing this wonderful academic activity. So in this pandemic times, though it is very difficult to have physical meetings, so it has been a blessing in this way that we are able to conduct more and more online meetings to connect with many people in their convenient times. So this is a good opportunity for each and every one of us. And it's a great pleasure and honor for me to introduce my dear colleague Arun to all of you. So he's an assistant professor of gastroenterology in DDHT Kilpauk, and also he has his own setup, Chandra Gastro Liver Clinic and Endoscopy Center, and he's also a visiting consultant in Billroth Hospitals. He's very much academically oriented and academically interested, and he has done his research in plasmapheresis in acute and chronic liver failure, alcoholic hepatitis, and also in post-liver transplant, immunosuppressants, and many other papers to tell. So he has been very enthusiastic about this program, about any academic activity. So it's a great pleasure for me to moderate this session and listen to him and moderate this session. So without taking much of the time, I would like to hand over the session to Dr. Arun. So over to you, sir. So you can continue now.
Thank you, Arun sir, for your very kind words. And without you, this session won't be complete. And it's a warm good evening to respected professors, senior consultants, and my dear friends who are being here, even during this COVID pandemic and complete lockdown, which is happening right now throughout India. And in this time, we are going to discuss right now an interesting entity in the field of gastroenterology, in which we are facing day in and day out. Every physicians, general surgeons, even the gastroenterologist will not leave the OP without this kind of presentation, which is nothing but a gastroesophageal reflux disease. So to discuss something about gastroesophageal reflux, to start with the main definition, what do you mean by gastroesophageal reflux? So it's nothing but any contents, something of stomach, if it is going to get reflux into the esophagus, is a common basic definition for GERD. And Montreal has taken over the definition in which if the patient is going to present to us with evidence of troublesome symptoms, or if the patient will be having some evidence of complications in the form, so much of other complications have been reported, if the patient is going to adversely affected for the individual's well-being is going to come down. So as per the Montreal statement, this is the definition for GERD. So So refluxate of gastric contents, which produces troublesome symptoms or complications. And the most common entity, the common presentation, as we all well know, is nothing but heartburn and regurgitation will be the most common presentation for GERD, or 80 to 90% of the population will be definitely exhibiting this kind of presentation, but it can present with other line of symptoms like chest pain, dysphagia, and multiple other complications. Even GI as well as extra esophageal manifestations also can report, that I'll be discussing to you in my upcoming slides. And if you are going to think about the epidemiology, so what do you to discuss about the epidemiology, because every patient was presenting to us in OP, so we'll be thinking more in terms of gastroesophageal reflux. Every patient will be presenting with dyspeptic symptoms. So the prevalence in northern part, in Europe and all, will be around 10 to 20%, but in India, it will be around 7.6%, and in urban areas, it's going up to 16. And in recent study, as ISG position statement 2019, what they mean concluded that in southern parts of India, the prevalence of GERD is slightly high, around 8.9%, and compared to northern parts of India is slightly lower, around 6 to 7%. That's what the recent study has been mentioned regarding gastroesophageal reflux disease epidemiology. So what is the reason? So why the patient, it's almost the iceberg tip. So most of the patients who present to with only mild symptoms, that is only minimal heartburn or regurgitation, will not seek the medical attention. But as the day goes on, if the symptoms is presenting more frequent nocturnal symptoms, if the patient is presenting with other manifestations, they may go for primary care physicians. And only very few patients who have chronic persistent symptoms and complications, followed by, they will be referring to the gastroenterologist for further evaluation and management. So it's always GERD to think about. And majority of patients will not seek medical attention, and only a very few patients see. If you're going to look into the slide, 44% of the patients will be having a monthly reflux, and 20% of the patients will be having a weekly reflux, and around 4 to 7% of the patients will be having daily reflux symptoms will be there. So only those patients who are present with daily frequent nocturnal symptoms, they will be coming to the gastroenterologist most of the time. So what is the pathophysiologic mechanism to discuss about this gastroesophageal reflux? So if you want to discuss about the pathophysiology, we need to have a basic knowledge about the basic physiology. So what is the basic physiology? One thing which we are supposed to know about the intact lower esophageal sphincter competence. So if the esophageal sphincter competence is well maintained, and esophageal clearance mechanism, which means there is no stasis, there is no evidence of esophagitis, the esophageal clearance mechanism has been well augmented, and the mucosal integrity has been well established, and the gastric emptying, which is going to happen in time. There are the 4 major physiological mechanisms which protect against esophageal injury. So what do you mean by the pathophysiology? It's a wide area to discuss about the pathophysiology. If you're going to look into the pathophysiology, the most common entity is impaired esophageal clearance. What's going to happen? Once the stasis is going to happen, reflux symptoms is going to present, there will be esophagitis, and the salivary secretion has to be adequate. Once the salivary secretion adequacy, if it is going to come down, what is going to happen? There will be a stages of esophageal contents that will also predispose to esophagitis. So impaired esophageal mucosal defense is another path. So what is happening? So there are so much of bicarbonate, mucosal protective agents will be there. So once the esophagus and the because of the gastric reflux, the esophagus is going to be exposed continuously to acid. So the esophageal mucus defense is going to come down. And TLS, transient inappropriate relaxation of the lower esophageal sphincter. That is also the most common important mechanism. Since the LES is not, inappropriately if it relaxes, so that will also predispose to severe GERD. And next to that, the reduced resting pressure of lower esophageal sphincter and the delayed gastric emptying. So what is going to happen? Suppose if you're a diabetic or something, you may have gastroparesis and other symptoms. You will be having delayed gastric emptying, and also the pyloric incompetence, which will predispose to duodenal-gastric reflux. There are multiple pathophysiological pathways to be explained in the discussion of GERD. So this is the basic anatomy. So how the LES mechanics is still maintained. As we all know that right from the beginning, right from our anatomy knowledge, what you are thinking about, the lower esophageal sphincter is distal 3 to 4 centimeters of esophagus. It is involving the right crux of diaphragm. also the intra-abdominal portion of esophagus, the angle of base and the phrenoesophageal ligaments all coordinate to form the competence of lower esophageal sphincter. So how the mechanism of reflux is going to happen because of one mechanism, nothing but TLES, that's nothing but transient lower esophageal sphincter relaxation. So if it going to be persist, see in between following, what is going to happen? There will be, if it's going to last for more than 10 seconds, the crural diaphragm activity is going to get inhibited and the reflex process is going to get started on. So around 50 to 80% of reflux is associated with TLEs. It's mainly, what is the stimulus for the TLEs? It's nothing but if the stomach is going to be distended with the gas or liquid, which is the mechanism for belching, that is the most important stimulus. That's the main etiology for the main mechanism for the GERD is nothing but an inappropriate TLECR, which is going to be maintained. And apart from that, a swallow-induced relaxation. That will also predispose to 5 to 10% of the patients with GERD because of incomplete peristalsis. If the food bolus is not going to empty the contents into the stomach, so incomplete peristalsis, what's going to happen? It will be lasting around 5 to 10 seconds, no crural relaxation. So this kind of presentation will be happening in patients with hiatus hernia. So if the gastric contents, if it is going to herniate into the esophagus, nothing but hiatus hernia. So this is one of the predisposing factor for GERD in patients with hiatus hernia. And apart from that, the other mechanics is hypotensive lower esophageal sphincter and the hiatus hernia. These four major things. One is because of TLECR and swallow relaxation and hypotensive LES and hiatus hernia. These four major things will be contributing in the pathophysiology of GERD. The symptomatology is very easy as a base, even so most common presentation, as we all know, that heartburn, it can occur in the daytime, it can occur in the nighttime. Nocturnal symptoms will be worsening. Your sleep, your routines will be disturbing, and you couldn't be able to concentrate your daily routine activities. And it usually occurs even after eating, and sometimes the pain may worsen with swallowing also. The sour or bitter taste, which is mainly because of regurgitation of the acid contents, sometimes halitosis. Many complications are there because of many symptoms. And to discuss the latest classification of Montreal in GERD, we will categorize a patient in based upon esophagus as well as extraesophageal symptom. So what is the esophageal symptom? One is symptomatic and any patient who presents with evidence of esophageal injury. So symptomatic syndrome is nothing but typical reflux and reflux chest pain. And if the patient is having Barrett's is nothing but columnar metaplasia. Normally, the esophagus has to be in squamous epithelium. If it is going to be a columnar metaplasia of the esophagus, it's nothing but Barrett's. That's a separate area for discussion. And sometimes, if there is evidence of esophagitis, stricture, esophageal adenocarcinoma, these are all the esophageal syndromes as per the classification of GERD. Extraesophageal, as we all well know that the cough, laryngitis, as we all know the tracheal pathway and the esophageal tract, it's being inverted with the common vagal tract, and micro aspiration will also be predisposing in that. The pharyngitis, sinusitis, pulmonary fibrosis, recurrent otitis media, these are all extra esophageal manifestations can happen in a patient with GERD. And even GERD can be reported in neonates and infants also. That's a separate area to be discussed. And I don't want to discuss all those entities right now. But even then, the established association with cough laryngitis has to be strongly encountered. So how will you diagnose this GERD? See, based upon one beautiful thing, one main thing what you're supposed to diagnose is the history taking and clinical examination is the most important thing when we are looking for the findings of a GERD. And the basic investigation, what you're going to do is nothing but barium swallow, which is not much of use nowadays. And next to that, the gastroenterologist will be planning for endoscopy. And if the reflux is persistent, if the reflux is very severe, the nocturnal symptom, then the patient may need ambulatory pH monitoring. If the patient is going for surgery or any other thing, if the patient is having severe hiatus hernia, if you're planning for any fundoplication procedures, then we need to go for the patient with ambulatory pH monitoring. And next to that, esophageal manometry can also be used if you are suspecting any motility disorders, esophageal spasm, anything else. Esophageal manometry is still having a role in the diagnostic in diagnosis GERD. So what is who are all the patient to be subjected for endoscopy? So any patient who presents to us with alarming symptoms, which means if the patient is non-responsive to medical therapy. And next to that, if the patient is having significant weight loss, if the patient is having evidence of bleeding symptoms, which we are not very sure. Sometimes the patient presents to us with evidence of upper GI bleed or melena. So the patient can present to us with the multiple bleeding episodes, which we are not encountered. And sometimes we can able to feel a mass, even the gastric mass or something. If you are going to suspect any mass, a stricture, or ulcer, suppose if the gastric ulcer is going to last for long, then the patient can go develop a stricture also. And even if your patient presents to us the evidence of severe extraesophageal manifestation, that what I have been discussed with you before, and if the patient is having persistent vomiting, these are all the patients we need to subject. And if you're planning for any surgery, any major endoscopic interventions, these are all the patients we need to subject for endoscopy. And so through endoscopy, what we are going to see, frequently I'll be giving report for the patients when you're doing endoscopy, we will use a Los Angeles classification. So what do you mean by the Los Angeles classification for evaluation of GERD? Once you put the endoscopy inside the esophageal tract, you will be seeing the mucosal breaks. So if the mucosal breaks is very small, less than 5 millimeters, it's grade A. If it is going more than 5, it's grade B. And if it is going more than, if it is involving around 75%, less than 75% of the entire circumference, will be around C. And if it is going to be more than 75% of the circumference of the esophagus, if it is going to be involved, then it has been labeled as D, Los Angeles grade D. So Los Angeles grade C and grade D will be having severe erosive esophageal, will be having severe symptoms, and we need to tackle the patient with good dose of therapy and good medications has to be done, with the significant follow-up has to be done to this kind of patients. So how will you categorize this patient endoscopically? Mainly by non-erosive. If you are going to put an endoscopy, if your endoscopy is going to be normal, doesn't mean that the patient is not having evidence of reflex. That's why we need to use ambulatory pH monitoring and impedance monitoring. Other things are there. So a significant amount of patients can be able to pick up. So even if the patient is having NARD, around 66% of the patients have been reported, and erosive reflex around 30 to 35%, and one more entity is nothing but Barrett's, will be around 6 to 12% of the patients have been reported as per the endoscopic classification. So to whom you're subject to esophageal biopsy, suppose if the patient have a refractory GERD, that I will be discussing in my upcoming slides. So what we are going to do if the patient is having evidence of severe esophagitis, or if you're suspecting eosinophilic esophagitis, if the patient has allergic manifestation, any allergic symptoms, and if you're suspecting any eosinophilic esophagitis, means if you're going to take a histopathology and if you're going to see more than 15 cells in the hypo field, it's nothing but eosinophilic esophagitis has been concluded. And we need to differentiate functional heartburn from a non-erosive reflux, and we need to see for the findings of in the esophagus like papillary elongation and basal cell hyperplasia and intraepithelial inflammatory cells, necrosis. All these findings can be taken into account. And always you should remember eosinophilic esophagitis also we should not miss out in a patient with GERD, because around 2 to 3% of the patients right now being diagnosed with eosinophilic esophagitis, even simple antihistamines along with even simple, sometimes even the monoclonal antibodies need to be established, need to be subjected to the patient based upon the severity of the symptoms. So there is a potential role for manometry. So, but in GERD, the role of manometry in GERD is of limited use. But if you're going to think in terms of achalasia, which doesn't mean, which means that if the failure of esophageal relaxation, achalasia cardia, if it's going to suspect, there is a very potential role for manometry. And what you're going to do in this, we need to assess the LES pressure. And if you're planning for a 24 hours pH monitoring, it will be useful in assisting the placement, and we can assess the esophageal peristalsis. So in manometry, you can see the pharyngeal pressure, upper esophageal sphincter opening pressure, and body and lower esophageal sphincter, the resting tone and the contractions, everything can be measured through the manometry. And if you're planning the patient for any anti-reflex surgery, we can do a manometry to that kind of patients. And the role of 24-hour ambulatory pH monitoring is the main potential thing for establishing the diagnosis of GERD. So what we are going to do, we need to see through a probe, we are going to introduce a sensor into the lower esophageal tract, and around 2 to 3 centimeters above the scomacolumnar junction, we need to place a sensor, and we need to monitor the pH continuously, and we need to see whether the pH is going beyond 4 or something, and reflex episodes is going to happen or not. Those, see, in this condition, what you're going to see, percentage of time, if the pH, if it is gastric, in the pH, if it is going less than 4, and also the DMIST scoring system is there, to evaluate the 24 hours pH monitoring. So what we are going to do, impedance pH metry, what we are going to use is, it's one of the gold standard in the diagnosis of GERD. And what are the patient to be subjected is patient who doesn't show any response to PPI therapy or incomplete response to PPI therapy, or if you're planning for any anti-reflex procedures, or if the patient is having more of atypical manifestations, then we can plan the patient for 24 hours impedance pH metry. So what you're going to place a probe inside lower esophageal junction, and you need to measure the pH. So, and this is based upon the catheter, and there is one more entity, wireless capsule device as being there, that I'll be discussing now. So will you dive? I mean, main thing, what is the DMS scoring for 24 hours esophageal pH monitoring is nothing but now how many percentage of total time, and based upon the upright time, supine time, in how many positions the patient's pH is varying, and how many reflex episodes is happening. Based upon that, this DMS score is being calculated to evaluate GERD. So if the patient is having more than 14.7, it indicates a significant reflex is happening. So if you're having a suspected GERD, and if you are being clinically proven that, so if you have a proven GERD, so how will you approach means we need to see it's a grade C or D, which means an involvement more than 75%, or Barrett's esophagitis is there or not, or if the patient is having any evidence of stricture. So what will it do? Then we need to, or if the patient is having any prior ambulatory pH monitoring testing, if it has been positive means, then we can subject the patient with double dose of PPI, and we can do a 24 hours pH monitoring for that kind of patients. And even if the patient is having unproven evidence, doesn't show any evidence of GERD, but upper GI endoscopy shows a grade C or D involvement, Barrett's esophagitis, atypical symptoms, and if you're planning for anti-reflex, these kind of patients also can be subjected for 24 hours pH monitoring, but off PPA has to be there for 1 week. If you're planning the patient for 24 hours pH monitoring, the main important thing is the patient should be off PPA most of the time for a period of 1 week. If the patient is to be being on H2 blockers, off H2 blockers for a period of at least 2 days, and nil by oral period for a period of at least six hours, and these things has to be strongly established if you want to do. And suppose if your patient is having antacids, over-the-counter medications, that has to be stopped at least 6 hours prior to the procedure, has to be enrolled. And see, based upon this pH monitoring, we'll be seeing that esophageal exposure and next to the reflex episodes, all those things we will diagnosed with that. And our target, if the acid exposure time, if it is going more than 6, it will be almost confirming the diagnosis of GERD. And the reflex episodes is more than 80%. It is almost abnormal findings in the diagnosis of GERD. So this is a very clear picture what's happening. Suppose, and see what you're going to do in this study is nothing but you need to subject the patient with medication and without medication. Most of the time the medication is PPI. So we need to do a pH monitoring. And if you're going to get a reflex burden, is nothing but GERD, it's confirmed. But normal reflex, but positive symptom means it's reflex hypersensitivity. The patient is hypersensitized to the tract. And even if the normal reflex and negative symptom that doesn't show any evidence of GERD. Likewise, if the patient is on medications, and if the patient is having abnormal reflex burden, which means it's persistent GERD. See, even if the patient is on medication, even with that, if the patient presents to you with evidence of GERD symptoms, means it's a persistent GERD or refractory GERD to be considered. So this is a multi-channel intraluminal impedance monitoring. What we are going to do, so we are going to place electrical, we are going to assess the changes, electrical flow between the 2 electrodes which has been placed in the gastroesophageal tract, where liquids, semi-solids or gas, which has been moved in and out around them. So it can also use, so if you're going to combine the pH monitoring along with a multi-channel impedance, so what is going to happen? It can able to distinguish an acid reflex. Also, you can able to identify a non-acid reflex, and you can able to analyze the flow of anti-grade or even you can analyze the flow which is retrograde, and many things can be diagnosed, and also whether the reflux rate is liquid or gas, everything we can able to diagnose with the complete combined. The sensitivity is almost going around 90 to 95% if you are going to use a combined esophageal monitoring and impedance, which has impedance manometry, impedance, multiluminal impedance we are going to combine. And this is nothing but a wireless capsule, which is the Bravo capsule. What you're going to do, instead of, we need to place this just above the stomach columnar junction in there through the endoscopy, and we need to measure through the radiotelemetry pH capsule. This to a transnasal pH monitoring has to be done. So what we are going to do, the external receiver is there, and the radio frequency signal will be there, and through that the signals will be continuously transmitted if you are having any evidence of reflexes. So what is the role in this? It's very easy to implement and the tolerability is very high, but the problem is non-acid reflexes. Suppose if the patient, we need to make sure that the Bravo capsule has to be there for around 48 hours. Suppose if the patient is being lasted only for 12 hours, means 12.5% of the patients being misdiagnosed if the patient is having evidence of, if the patient is not being diagnosed. So how will you manage a patient with GERD? To discuss about the management of GERD, as we all well know, the most important entity is diet and lifestyle modification has to be strongly addressed. Next to that, the drug therapy. And third is analyzing, picking up the symptom for refractory GERD. And fourth one is subjecting the patients for endoscopic management, whether it is needed or not. And fifth one, whether the patient deserves surgical indications is there or not, and we need to follow up the patient in a strong manner. So this is the baseline as per multiple guidelines are there. One is American College of Gastroenterology guidelines and WHO guidelines, NICE guidelines, various position statement, ISC task force guidelines in 2019. Many guidelines are there. Based upon that, so we need to categorize the patient with evidence of esophagitis, and we need to subject the patient, whether the patient is having single dose PPI or double dose PPI, whether the patient is improving or not, and we need to categorize the patient even after 6 weeks of treatment. If the patient is not improving, we will categorize the patient as refractory GERD. So suppose if you are going to label the patient as a refractory GERD, means we need to see whether the patient is having esophageal symptoms or atypical symptoms, and we need to calculate, we need to see the impedance monitoring, and the ambulatory pH measurement is the most important entity to be assessed for this kind of patients, the most important entity to be enrolled. And so what is the effectiveness of medical therapy for GERD? So there are, suppose if they're going to put the patient lifestyle modification and basic lifestyle first line of medication like Antacids, where most of the practitioners are being using, 20% will be improving, and H2 receptor blockers around 50%, and single dose PPI around 80%, and double dose PPI definitely there will be around 90 to 100% response will be there if you are going to use double dose PPI. So lifestyle modification means eat frequent small meal, elevate your head end of the bed, and make your meal time at least 2 hours before your bedtime. Nocturnal meal at least 2 hours before, and avoid eating caffeine, high carbonated drinks, stop alcohol, smoking. These are all well known, but whether we are focusing in that, whether we are doing that, that is the most important question. Even these kind of things still remain below the iceberg, but even these kind of things we are not following. That is the most important thing to be taken care. And if you are obese, reduce your obesity, stop alcohol, and avoid peppermint food, chocolates, various coffee drinks, and other things has to be avoided. And so OTC medications has to be avoided. Definitely your BMI has to reduce to less than 25, and that's so losing. It's a weight loss is the most important entity. If you're reducing at least 2 kg of weight, the GERD symptoms will definitely be improving. And so why means, so it will be acting on interleukin pathway and TNF pathway, and multiple pathways are there, will be affecting the mechanics of lower esophageal sphincter. So what are the various, this are the, so there are the various merits are there. So it will be definitely, once you reduce your weight, not only release the symptom of GERD, but other associated complications of obesity will be addressed. And some demerits are there even for lifestyle modification, because our patients are not adhering to that. But even after we're strictly adhering to that. How many patients are having the reflex symptoms is coming down? It's still a questionable issue, but the convincing. So food prohibition, indiscriminate food prohibition also reduces the compliance, and it should be avoided. The huge list of drugs, as we all well know, that one is Antacids, the first one, and H2 blockers, PPIs, the main area to discuss, prokinetics. Antacids, the alginic acid preparation can be tried. So what it's going to do, it will be going to float in the salivary acid pool, and from there into the gastric secretions, where is it going to form a raft which co-localizes with the acid pocket, and it produces significant acid suppression. So what is the problem with antacids means? You need to use a frequent dosing. Frequent dosing has to be done, and some major complications are there. That has to be addressed properly. But there are some trials, if you're going to use omeprazole or alginates, if you're going to use a 14-day trial, and if you're going to subject the patient with alginate around 10 ml 4 times a day, so it doesn't mean it's been equally potent, that has been shown. But even with that, the merits is it will be suppressing the acid secretion rapidly, but more rapidly than PPI, but mild symptoms will be addressed, and it's also a cost-effective thing in the managing a patient with GERD. But what is the demerits? What are the demerits? Nothing but the patient may have rebound hyperacidity. The action will be lasting for only 1 to 2, 3 hours, and again the patient will be having symptoms. It doesn't going to involve, it doesn't going to take care of your esophagitis. The erosive esophagitis will not be improving. The Los Angeles state will still remains the same. So what is the point in treating that? So the side effects are high. If you're going to use aluminum compounds, you may have constipation and other manifestations. If you're going to use magnesium compounds, you may have diarrhea, and there are multiple drug interactions is there. So considering antacids is still a questionable, but even then we are using frequently our day-to-day practice. So H2 receptor antagonists, as we all know, multiple drugs are there. It's going to block H2 receptors and it decreases acid secretion. The multiple drugs are there like cimetidine, ranitidine, famotidine, and the recent one, lafotidine, even luxotidine. Multiple modalities of drugs are there. So if you're going to think about lafotidine, so the main role of H2 receptors as a gastroenterologist is what is the main indication? So we'll be taking care of nocturnal acid breakthrough. Suppose if you're going to subject the patient with only PPI in the daytime, and they're putting the patient with PPI in the daytime, and if you're going to subject the patient with H2 blockers in the nighttime, so the patient's nocturnal acid breakthrough episodes will definitely come down if you are going to use H2 blockers, which is being combined with PPI. So it's reasonable, it's cost effective if you're going to use H2O, but if you're going to use for grade 1 to 2 esophagitis, 60 to 90% response will be there. But grade 3 to 4, the response will be only around 20 to 30% of response will be there, and less of drug interaction is there. But there are certain demerits for H2 blockers, like that short duration of action and less potent than PPI. And tachyphylaxis, always you should remember, suppose if you're going to use frequently, the response is going to come down. That's nothing but tachyphylaxis is always one common adverse effect being reported with H2 blockers. Side effects, not much, but few hypertensive episodes, few diarrhea, constipation, and one major thing is cimetidine is gynecomastia, as we all well know. That's why we are not using that drug nowadays. And multiple interactions is there, cytochromal interactions and cimetidine, which is more potent than ranitidine, causing these interactions. And these are all the major things to be discussed. And the main area is PPI. So PPI, how does it act? The proton pump. So the proton pump is being located in the parietal cell, and it is being continuously secreting. So what's going to happen? The continuous acid process is going to be enhanced. So here, if you're going to take, for example, if you're going to take omeprazole, so it is going to inhibit the hydrogen potassium ATPase secretion, which is happening in the proton parietal cell. So what is going to happen once the hydrogen potassium ATPase secretion is going to be blocked, and the hydrogen now release will be coming down, and the patient's acid secretion will be inhibited. The problem with PPI, so it will take to act in the parietal cell in the mechanism. It will be taking around 5 to 6 hours to act. That's the main problem, and immediate response will not be happening. That's the most important thing when you're going to use PPI. And next to that, Why? Because there are multiple modulators are there. One is because of gastrin, one is because of ACH, one is because of histamine pathway, and all these things is being released from the gastrin, which is being happening from the ACL cell and entroptomorphin-like cells. These are all the major pathways being involved in the mechanism of action of omeprazole. The main role is hydrogen, potassium, ATPase. But one good thing is it irreversibly inhibits. So the acid pocket will take more time to secrete. That's why if you are going to subject the patient in morning, nowadays dual release technique are there, like pantoprazole has been well available in the market. Pantoprazole has come around 80 milligrams nowadays. So dual release technology is initial 1 hour followed by 5 to 6 hours peak is there, and next to that dexlansoprazole. Multiple drugs are there which has been tried, and these are all the dual release potency, and sometimes double the dosing morning and night, and sometimes when you are going to combine morning PPI and nighttime nocturnal H2 blockers, that also can be combined based upon the response. So these are all the basic drugs. Nothing much to discuss in this. Esomeprazole, Lanzo, Amaze, Pancho, and tanotoprazole is one recently available drug, and dexlansoprazole will be used even 30 and 60. The one good thing about dexlansoprazole will be having an enantiomer form, and it will be having a dual release technology has been there. And also for pantoprazole nowadays, about 80 milligrams, the dual release technology is there. And usually double the dose, step up and step down approach. Always you should remember what is step up and step down in managing a patient with GERD. Once, if you're going to subject the patient with PPI, suppose if the patient is having severe esophagitis, we need to start the patient with the step-up approach. Directly, we need to go for double dose therapy. And once the patient starts responding, as the time goes down, around 8 weeks of phase, if it is improving, then we can go for step-down therapy. And if the patient is having only mild to moderate symptoms, then we can go for step-up approach. Step-up approach from H2 blockers by antacids. Slowly, we can augment depends upon the clinical presentation. So the main indication for PPI is having a maximum concentration at 90 to 120 minutes and more prolonged acid suppression, and it will always maintain the pH approximately around 10 to 14 hours. And once daily dose, most of the time will be suffice, and it will be relieving heartburn symptoms of severe GERD. Also, erosive reflux, esophagitis, the healing rate will be potentially higher. It will be around 60 to 70 to 80% of healing rate will be there if you are going to use PPIs. So these are all the major merits for PPI. As I discussed, dexlansoprazole, enantiomer, and always you should remember PPI is available over the counter and everywhere, even physicians, surgeons, everyone is using day in and day out. Without PPI, the management process will not be complete. And so one problem, the demerits is nocturnal acid breakthrough that we are supposed to remember. That's what I've been discussed previously. Sometimes we may need H2 blockers to compete with that. And apart from that, so what will happen, as I told you, so since it's irreversibly inhibiting the proton pump, so we need to wait for the PPIs to accumulate to bind, and it will take such a long time. That's why the immediate response will not be there, and it's somewhat, some drugs are slightly costlier, and it does not cure the reflux completely. Regurgitation does not have a robust response to PPI, and total number of reflux episodes and proximal extent are not affected by PPI therapy. So there are demerits based upon 3 reflexes will be encountered. What are the reflexes? Suppose if the patient doesn't shows good response to PPI therapy, which means the patient is having a weak acid reflux, could be one mechanics for GER, or it may be alkaline reflux gastritis, that may be one mechanics for GER, or it could be a duodenal gastroesophageal reflux, that may also be one mechanics, and there are multiple drug interactions are there. And basic side effects, as we all know that the dangerous side effects, that's the most important entity. It can predispose to acute kidney injury, and sometimes it can predispose to chronic kidney disease, and sometimes also it be involving causing osteoporosis, hypomagnesemia, dietary iron absorption will be reduced, and funding gland hyperplasia and rare tumors also have been reported in mice and rats, but still more studies are going on and still much indication. But if you are going to subject the patient to PPI, we cannot label this PPI as superior to this, but even with that, If you're going to if the patient is going to consume PPI for a longer duration, years together, then there is high possibility for the patient to go for funding gland hyperplasia and malignant changes to take over, dysplastic changes to take over. So this study shows, suppose if the patient, so compared to placebo, if the patient is going to subject with PPI therapy, all the symptoms is going to improve. Esophagitis, heartburn with esophagitis, there is a significant response being there if you are going to use PPI. So regarding prokinetics, so next to that it's a prokinetic, which is mainly based upon when we are using prokinetic, we should be very, very cautious, and we need to assess a clinical parameter of the patient, and to which patient we need to subject the patient subject with PPI is the most important thing we need to assess. And the mechanism is mainly it increases LES tone. Once the LES tone increases, the reflux will definitely calm down, gastric emptying augmentation, and intestinal motility will be enhanced. So mainly by two mechanics. One is by D2 antagonism, and next to that is 5-HT3 receptor modulation. It could be 5-HT4 or it could be 5-HT1. There are multiple drugs are there for PPI, domperidone, metoclopramide, ichapride, and glyvosulfide, and sinichapride. My choice will always be, as a gastro, will be thinking about, sometimes I'll be going for ichapride. Most of the time, among the PPI is one of the best of PPI that we'll be recommending, because it will be also acting on the acetylcholine esterase inhibitor pathway, in which the acetylcholine release will be suppressed and the histamine tract will be suppressed, and this patient, the response of prokinetics definitely will be reasonably high when compared to other drugs. So among the doses, as we all know that if you are subjecting the patient with sinichapride, or very less of brands being available, sinichapride 1 milligram TDS, levosulfide we can go for 25 milligrams TDS, ichapride 50 milligrams TDS, domperidone is well known, 10 milligrams TDS can be considered, but the main merit is it improves increases the LES tone, thereby preventing the reflux, but not much of costly. The demerit is it doesn't alter the transient lower esophageal sphincter relaxation. So the problem is effectiveness will decrease with this severity. Modest benefit will be going to happen if the patient is having evidence of heartburn, and there are multiple adverse events. It will cross the metoclopramide, for example. If you're going to take it, will cross the blood-brain barrier. That's why we'll be subjecting the patient with etopride, because the blood-brain barrier crossing for etopride will be slightly low, and the prolonged duration of action with etopride is slightly being augmented. And if you are going to think about metoclopramide, extrapyramidal symptoms is well known, and domperidone is also but it's not having much of effect. Sometimes hyperprolactinemia can be there. Cisapride definitely not to be used in withdrawn because of cardiac events. And next to that, what is the role of baclofen? Many patients have been seeing with baclofen, it is going to inhibit the transient lower esophageal, it reduces the TLER, transient lower esophageal sphincter relaxation. So if you're going to subject the patient with around 5 to 20 milligrams, so slowly we'll start the patient with baclofen. So what is it will definitely reduces the TLER and the acid reflux and urine reflux. Everything is going to come down if you're going to put the patient with baclofen add on to a PPI therapy. Studies are there, but the problem is drowsiness, dizziness. Some rare reports are being there, and many drugs like ibuprofen, many drugs have been withdrawn from the market because of limited clinical efficacy. So to discuss about the drugs, next to that, if the patient being even after the drugs or double dose PPI for the duration of 8 weeks will be definitely have been defined as refractory GERD. Suppose if the patients are refractory GERD, around 30 to 40% of the patients will not be respond to PPI therapy. There are multiple studies in Chinese study. If you are going to look into that, the patient have been subjected who are all been not responding to GERD, they have been subjected for that, and with that they have been evaluated. More cases have been reported with the PPI refractory GERD. And next to that, if you're going nocturnal acid breakthrough H2 receptor, that's what I have been discussed. When you're going to combine your PPI with H2 blockers, your nocturnal acid breakthrough definitely is going to come down. See, so always around 60 to 80% patients, nocturnal acid breakthrough episodes is more common if you're going to use PPA alone. So that's why you need to subject the patient with H2 or in the night time along with PPI in the morning time can be tried. Tachyphylaxis, as I already discussed with you, the case reports are still high. Tachyphylaxis is one common adverse event which has been reported when you are going to use a patient with H2 receptor antagonist. So what is the role of potassium competitive acid blocker? There are some new innovations. One drug which is being classically used is vonoprazan. The dose is around 10 milligrams to 20 milligrams can be tried. So what is it? It's going to reversibly inhibit, like irreversible inhibition by PPI, but this is going to inhibit the H2 hydrogen potassium ATPase reversibly by competing with potassium. So eye accumulation. So what is going to happen? The mealtime depend means always the nocturnal symptoms also been well suppressed if you are going to use the potassium competitive acid blockers, and reflex episodes, erosive esophagitis in all the areas, and the efficacy of the drug has been proven, but we need still more trials to accept this widely in the market. Always we should remember the functional dyspepsia is one more common entity when you're tackling the patient with GERD. And the functional heartburn, hypersensitive esophagus, these are all the patient, even if you're going to subject with PPI, H2 blockers, the patient will not respond. So what are you supposed to do? We need to put the patient with either SSRI, or sometimes the patient has to be subjected with TCA, and based upon that clinical assessment, we need to see whether the patient is responding or not. And there are huge list of drugs which is being tried, and the multiple trials have been going on. And one few things we want to discuss: cannabinoid antagonist is there, cholinergic receptor antagonist is there, and VCAM. It's nothing but PPA combination around the dose of 10 milligrams can be tried in the newer molecule. And azithromycin, always you should remember it's a motilin agonist. Azithromycin, macrolides, which is being acting as a prokinetic, can be tried. And if you are going to use a pain modulator pathway like TRP, that's a transient relaxation of vanilla receptors, these kind of pathways modulation, there are so many mechanics, so many things, and so many new molecules being tried in the management of GERD, but still needs more clinical trials to prove its efficacy. So when do you suspect the patient is non-responsive to PPI is nothing but if the patient is having evidence of what are the causes for refractory GERD, which means if the patient is having hypersensitivity, esophagus, the functional heartburn will not always respond. Even if you put the patient with multiple therapy, he will not always respond. And most of the time in your OP, the patient will say, sir, I'm having pain here, I'm having pain in the abdomen, I'm having chest pain, I'm not responding, I'm not having sleep. So we'll be confusing whether we are tackling something or we are missing something. So over-diagnosing will lead to over problem. Next to that, delayed gastric emptying and rapid PPI metabolism, poor adherence to the drug. If you're not going to take the drug properly, these are all the various huge list of causes for refractory GERD. But what are the causes which is unrelated to GERD that will make the patient non-responsive to PPI? For example, Zollinger-Ellison, the high gastrin levels is going to happen. That will also, PPI response will not be good. And autoimmune disorders and infectious disorders in esophagus. Sometimes if the patient is having esophageal cancer, or if the patient is having NSAID abuse or radiation esophagitis, there are multiple list of causes to assess a patient non-responsive to PPI. And we need to see these kind of things clearly in our history prior to thinking the patient is responding or not. So coming to the endoscopy, beyond medical, there are something which is newer in the field of gastroenterology to be discussed. And as a physician and surgeons, you should know that what's the thing which is happening. And endoscopic and laparoscopic techniques are there. And we can, suppose if the patient develops complication, we can go for dilatation. There are multiple dilators are available. And suppose if the various endoscopic techniques are there, which has been very new, innovative, which is happening. And for a sewing technique, and you can burn out the lower esophageal tract, and we can use a knife procedure, and we can put some implants, and you can try from bipolar electrical stimulator and alternative medicines, alternative therapy, hypnotherapy, cognitive behavior therapy. There are multiple things that are there in the management of GERD. So briefly to discuss about the endoscopic therapy is, we need to go for RFA, radio frequency ablation can be tried, in which strata is being used, and we need to go for the fundoplication, means esophagus, muse, which is nothing but, and we can also go for Gerd, and we can also go for anti-reflex mucosectomy. These are all the major headings to be categorized. So what is going to happen in Strator procedure? You are going to see, you are going to place a electrode into the lower esophageal tract and the lower esophageal sphincter along with the cardia. We need to puncture with multiple radiofrequency ablation, and also you can use a mucolytic. So first, if you are going to see the diagram 1, 2, and 3, first we need to position the electrode, we need to place and inflate, deploy, and multiple levels has to be done. And so what is going to happen? The systemic relief through reduction of tissue compliance and enhancement of anatomic resistance at the GE junction will be well maintained. So the various merits are there. The minimum thing, it will not require surgery, but the cost effect is still high. It can be done in an outpatient procedure and no much of surgery, no incision, no stitches or implants needed. And the few demerits for strata is can predispose to gastroparesis. Some patient can present with esophageal perforation. Gas and blotting effects can be reported. This procedure, the BARD endocrine, this procedure has not been used much because of much of potential benefit with this procedure is definitely low. So nowadays in gastroenterologists, this procedure has not been a favorable one. And so briefly to discuss is, so what we are going to see, just we need to suck the tissue beneath the Z line, and we need to put the needle in, and we need to put the sutures, and we need to placate the cardia. That is the main thing. So once you do this, what's going to happen? It's going to alter the LES system, LES function. Everything is going to get altered. And what is the demerit for this procedure? The patient's high failure rate is there, and the patient can have retrosternal pain, sometimes bleeding episodes. Some patient can present with the acid exposure will be persistent. The esophageal acid exposure will be remain unchanged even with these procedures. So if you're going to think about the transferal incision, that the TIF repair, if you're going to remember that TIF is more than enough for us before winding up this session. So if you're going to think about esophagus means, so what you're going to do, it's nothing but a transoral incision less fiber fundoplication. What you're going to do in the gastroesophageal junction, we are going to placate, and the gastroesophageal flap mechanism is still going to maintain. So if you're going to see this esophagus, they'll be having multiple dynamics in that. That a handle is there, and so many things are there to consider for the esophagus to be used. And the early results, and what are the major adverse effects if you're going to use esophagus is being very minimally invasive, and it's going to reduce the hiatal hernia, and it's going to reconstruct the new gastroesophageal valve and restore the function as a barrier, and no external incisions being needed, and purely a endoscopic procedure. And what are the demerits? Sometimes if you it may, because of the strata, sometimes it may going to damage your vagal nerves, which is being innervating the lower esophageal sphincter, and certain population studies still need to be done because we are not subject this procedure in India for multiple patients. This is another one. This is a Gerd procedure. What we are going to do that. So always you need to, so mainly in the greater curvature of your stomach. So what you're, the junction, what you're going to do, the multiple plication of the implants can be placed. So we need to open this arm. See, if you're going to see this teeth, we need to open the arm, and we need to fix the tissue, and we need to close the arms, and we need to apply plicators. So multiple plicators can be applied. This is nothing but a Gerd procedure being demonstrated in very major centers in India, in AEG and other centers being tried, this modality of treatment also. And injectable materials, multiple materials are there, but doesn't show much of effect. So it's not been much valid nowadays in the management of GERD. For example, Entrex is nothing but it's a biomolecular polymer, and plexiglass is nothing but it's polymethyl methacrylate beads. So Durasphere is also coated with the carbon bead. There are so many things being tried. So what you're going to see in that, once they're going to search in the gastroesophageal junction, they are going to create an anatomical barrier to reflex. So initially it attracts because of simplicity, but the efficacy and the studies doesn't show a good improvement of symptoms. That's why it's not being used nowadays. And this is another technique in which you are going to use a stapler technique. It's nothing but Muse. What you're going to do, it is a three-step approach. Muse is nothing but a Mediger's ultrasonic surgical endostapler. So I don't have the diagram or picture or video to show right now with you, but what you're going to do, they are going to do, retroflex the stomach, and from there, they will withdraw into the 3 centimeters above the gastroesophageal junction, and they are going to put a stapler on that. So that's nothing but a surgical endostapler approach. And the main thing is perioperative chest discomfort and sore throat, esophageal injuries can be reported. And next to that, harms procedure. This is anti-reflex mucosectomy. In this procedure, what we are going to do, we are going to inject, so it will be involving the lower esophageal sphincter, also the cardia. So what we are going to do, we are going to inject a saline. See, first diagram here shows a saline injection, indica common dye has been injected. So we will be, this is either by 2 techniques, one by cap assisted technique and one by band assisted technique. So if you are going to use it in this picture, we are showing the cap assisted, the application of snare over the mucosa and cap, and what you are going to do, the mucosal resection. So we need to create a semicircle resection around the esophageal mucosa. So almost 2/3 of the circumference will be completed. So what is going to happen? The bleeding, sometimes the bleeding spurt will be there. That has also been effectively controlled. So the major merit of this anti-reflex mucosectomy is it will be predominantly the greater curvature of the esophageal gastric junction will be always well preserved, but the lesser curve only will be shortened with scar formation. So the robust angle of this will be well maintained, and the mucosal flap valve mechanism also will be well established. These are all the merits. Always the demerits will be a bleeding and perforation, expertise needed. And next to that, another innovative is the reflex management and length procedure. What they are going to do, so in this, we are going to see there is a magnetic bead around the OG junction. So what they are going to do, they are placing around few magnetic beads. What's going to happen if you're going to place a magnetic bead around that? It's a titanium beads with magnetic cores. What's going to happen? If you're going to take the food, oral diet will not be stopped, but the reflex of contents will be temporarily stopped. So this is designed in such a way the magnetic bond will be breaking, allowing food and liquids will be normally passing into your stomach. But the reflex episode will not happen. So it's very easy. So it's what are the merits? So it's a natural sphincter mechanics. So as we have discussed, the normal physiology, the normal augmentation of the physiological barrier will be well maintained by this procedure, and we can go home on the same day. The side effects is very safe and effective, but so demerits is patient needs GA, and sometimes dysphagia and vomiting can be occurring, and you can't do MRI because it's a magnetic issue. So MRI for this kind of patients we cannot do. And this is a surgical approach. If the patient is having persistent symptom or reflex, if the patient is going for surgery, surgery is one-stop cure for the patient with severe GERD. And surgery, if the patient will get multiple fundoplication procedures there, our main entity what we are going is nascent fundoplication, and one anterior fundoplication and posterior fundoplications are there. Anterior is nothing but thigh and also the door fundoplication, and posterior is nothing but the two-patch fundoplication. Posterior fundoplication is mainly for esophageal motility disorders, and anterior wrap is mainly for achalasia, after LS myotomy in patients with achalasia, So anterior fundoplication, posterior wrap can be tried, and multiple merits. So it's one-time cure, and the usage of PPI definitely is going to come down, and it's almost safe and effective. But the demerit, sometimes you may have bloatedness in your stomach, flatulence, diarrhea, and some of the events can be reported. So this is various studies. This has been an overview of the various endoscopic approach what we have been tried with Stretta, TIFF, and Muse. In that, the response depends upon, and still we need more trials to compare this. But in India, at least when we have been using for a few centers, few persons, we have been used that, and the treatment response will always be good in Stretta as well also for TIFF procedure, and the durability will be almost 6 to 10 years for all the procedures will be reported. But some severe adverse events also been reported that has to be strongly enforced when you are managing a patient with GERD. So to conclude, always you should remember, before concluding, I would like to say a few things. Clinical history and assessment is the most important thing in managing a patient with GERD. And next to that, we need to categorize the patient with evidence of gastroesophageal reflux disease is there or not, and if the patient is having non-erosive reflux, or if the patient is having evidence of Barrett's, or if the patient is having evidence of alarming symptoms that what we are subjecting the patient for endoscopy is needed or not, and to whom all the patient being subjected to pH metry and monitoring and impedance monitoring has to be done, whether the patient is being having evidence of any esophageal motility disorders. All these things has to be properly assessed, and we need to start the patient with first line of medication. If it is non-responding, then we need to see with the pH metry whether the patient is having a reflex episode or a non-reflex episode, and everything has to be ascertained properly. And dual dose therapy and double dose therapy, these are, I mean, along with and this all the modalities and PPI at higher dose, step up and step down approach of PPI, and subjecting the patient for surgical management and subjecting the patient for endoscopic approach. Everything has to be done, and everything has to be assessed properly before managing a patient with GERD. So 24-hour pH monitoring is a gold standard in diagnosing the patient with GERD. With that, I would like to wind up my session and thanking you all for patient listening. I feel really happy, and I'm happy to share. I mean, if there is any questions to take over right now.
Thank you, Dr. Arun. So, thank you for this very comprehensive talk. You have not left anything untouched. You have covered everything, starting from the pathophysiology, symptoms, mild disease, refractory GERD, medical management, endoscopic therapy, surgical therapy. So you have comprehensively covered very well structured talk. I thoroughly enjoyed it. My congratulations.
Thank you, sir.
And from the audience, we have a few questions. I will just read it for you. One is Dr. Satish from Kanchipuram. He has asked for what are the classic symptoms of GERD?
That I have been discussed in my first slide itself, sir. Dr. Satish, the most common presentation will be heartburn as well as regurgitation. That will be encountering around 80 to 90% of the patient with evidence of GERD, you will be coming across.
Okay.
Apart from extra GI manifestations, we'll be reporting around 15 to 20% of the patient's case reports are there.
Yeah. Dr. Anbu from Dindigul has asked, is prolonged use of omeprazole causes carcinoid tumor? And another question is, which is the best prokinetic that you suggest?
So prolonged use of PPI, that means omeprazole causing carcinoid tumor. Definitely case reports are there. I have seen one article what they have been mentioned for a patient with suspected follicular lymphoma or something, in which a patient has been subjected for a longer duration of PPI therapy. In that, since what is the reason is, if you are going to use PPI for a longer duration of time, in carcinoid tumor, it's nothing but a neuroendocrine tumor. So what is going to happen? In that, the chromogranin pathway will be affected. So if the chromogranin release, if it is going to be affected, if it is going to be augmented over the duration of time, the patient can go for evidence of carcinoid tumor, and the case reports have been there. And but we should not think all the patients will be going over there, but very few reports are there for the patient, but still it's validated to be considered. And next to that, the best prokinetic, as my practice, and there is no molecule which is superior or inferior. In my practice, we'll be considering etopride is one of the best prokinetic, because when you're going to subject with the patient with other drugs, there are multiple adverse effects, and the patient will be having a blood-brain barrier crossage. So etopride 50 milligram GDS will be definitely having a reasonable benefit. So in my experience, I would like to consider etopride to be added with PPI in management of gastroesophageal reflux disease.
So next question is from Dr. Kannan, N. Kannan, diabetologist from Chennai. So he has asked, like most of his diabetic patients are having stress-induced GERD or autonomic gastroparesis. So what are the guidelines, which guidelines, clinical guidelines to follow for patients presenting with these symptoms? This is his question.
Clinical guidelines, see what is the reason for a diabetic patient to have a gastroparesis? Mainly because the gastric emptying will not be proper, and next to that the inhibitory reflex will not be adequate, and the lower esophageal sphincter pressure will not be maintained, and the TLACR will be more augmented. That's a frequent augmentation will be there in case of diabetic gastroparesis. So what is going to happen? Once the patient is going to subject the patient to diabetic gastroparesis, we need to choose a good prokinetic molecule to be targeted. And there are multiple trials are there. Even for diabetic gastroparesis, sometimes we be subjecting the patient with ichopride, and there are other molecules also been, cinetropride also been considered in the management of diabetic gastroparesis. And the one thing when we are tackling, always we should remember when we are subjecting the patient with diabetes, with prokinetics, some effect of diarrhea and other complications will be reported. And next to that, there are multiple, even for Diabetic Association Society, RSSDI, been reporting the usage of ichopride and cinetropride in case of diabetic gastroparesis management.
Okay. One final question. Like two doctors have posted a similar question. Dr. Bharat from Pondicherry and Dr. Sujay Sukumaran from Nagarkoil. Both of them are possibly pediatricians. They are asking about which is the better drug to be given for drug of choice for kids with gastritis and GERD, and how long it can be used.
Ideally, when you are subjecting the patient for gastritis, see there are, you can say it's GERD or you can label it as gastritis. By ideal thing, you need to give a patient with PPI mainly at least for a duration of 8 weeks. But if you're going to subject the patient with 8 weeks of therapy, it be even after that if it is not improving, it's be labeled as refractory. But minimum duration of 4 weeks of therapy has to be given for you to see whether the patient is responding to therapy, whether the patient shows evidence of clinical response, even in erosive esophagitis, or if the patient is worsening with symptoms, even in NERD.
Okay. Thank you. I think if anybody in the chat box or anybody want to post the question, you can post in the chat box or you can ask directly. If anyone else having any queries. So in the meantime, I just want to have a question with you. Like in which patients you directly we give only proton pump inhibitors, and which patients you add either an prokinetic or H2 blockers in the beginning itself. How do you choose?
So in my experience, if the patient is of young age, if the patient doesn't have any major manifestations, if the patient doesn't show evidence of any clinical pointers in favor of functional or hypersensitive esophagus, then I will subject this kind of mild to moderate symptoms with no major alarms. First line of therapy, I'll always go for a prolonged release of PPIs. PPIs is the first line of modality, and so following that, I will assess the response. And even after that, if the patient not responding, I'll be going for a slightly the dual release drugs of therapy like dexlansoprazole or pantoprazole can be combined, can be tried. Even after that, if it is not responding, and if the patient is having PPDS, postprandial distress, then I will be subjecting the patient with other line of molecules like prokinetics or acroshiamide. Those kind of drugs can be subjected only based upon the first line of molecular PPI responsive.
And you mentioned about many endoscopic modalities, so these are all eye openers for me as well as for all the audience. So hopefully in future, many endoscopic therapies are becoming day-to-day practice for GERD and approved.
Our centers need more training for this procedure, so that's what we have been, but we need to more focus on that. Sir.
Yeah. If there are no more questions, we can wind up the session. Still, okay. Good. Yeah, some more questions are there. Dr. Saravanan from Chennai is asking, how long do you give treatment for GERD? You can elaborate on that. Right?
Already I have discussed the ideal line of treatment with GERD is to give minimum period of 4 weeks, but there are multiple trials being shown, even period of 8 weeks and 12 weeks being given. But longer duration of therapy is more significant depression of heartburn and other episodes. Even the extra esophageal manifestations will be definitely coming down if you are going to subject the patient with around 8 weeks of therapy for with PPI. Sir.
One more question is, how long PPA can be taken? So again, you have mentioned, but still, Dr. Selvakumaran is asking this,
how long is for around 4 to 8 weeks is the main line of treatment, but how to treat with PPI is one thing I want to address, because around minimum period of around 30 to 60 minutes before a meal has to be taken, and the usage of PPI will always be augmented to prevent the nocturnal acid breakthrough if you are going to combine with H2 receptor blockers. And nowadays there are some trials been proven that ADMA, other possibility of ranitidine and other things, but still it's not been more validated. And next to that, lafotidine has been recently well trained nowadays. I mean, tried nowadays to in the usage of nocturnal acid breakthrough episodes, to which I'll be subjecting the patient with either 10 milligrams or 20 milligrams of lafotidine to prevent the nocturnal acid breakthrough, sir.
And one final question from Dr. Saravanan again. How often have you come across interstitial nephritis in long-term use of PPIs? And any role of H pylori and probiotics in GERD? So these are all the questions.
So one important thing I would like to answer, but I forgot to mention in my initial slide about the role of H pylori and GERD, because the GERD will be having a different outcome when compared to H pylori. So if you are going to treat the patient with H pylori like triple drug regimen or 4 drug regimens, if you are going to use, doesn't mean that you are not be having a GERD prevention. Nowadays, even lactobacillus literally being tried in the management of H pylori eradication, which shows sensitivity approximately around 70 to 80%. When combined with around triple drug therapy or 4 drug therapy, the sensitivity will be going around 80 to 90% in the management of H pylori. But even after all this, the controversial issue is still going on, and the patient response of GERD, the clinical manifestations of heartburn, reflux episodes, doesn't mean that it will be fully cured of. And many patients, even after H pylori eradication, around 40 to 50% of the patients, case reports are still being reported, will be having evidence of GERD. So treating H pylori means doesn't focus on complete eradication of GERD. So always we need to tackle the GERD with the diet and lifestyle, along with the drug therapy, along with eliminating their triggers and other responses.
And one more question is, again, we have discussed, like sir is again asking, when do you suggest surgery for GERD? This is one. And then Dr. Ramasamy from Chennai is asking, functional dyspepsia, what is the management?
Functional dyspepsia, it's a very important entity to be discussed, because it has been broadly categorized as per the Rome criteria. So functional dyspepsia can be divided into postprandial distress or functional abdominal pain syndrome. There are multiple things there. For functional dyspepsia, nowadays we have been trying for postprandial distress. Acosamide is one very good molecule that will be used around 100 milligrams. When you are going to use acosamide, there is evidence of postprandial distress definitely is going to come down. Postprandial blottiness is definitely having a good response. But if the patient is having functional dyspepsia, the psychological impact has to be taken over. The other line of therapy has to be done. Antidepressants, sometimes SSRI and TCA, definitely having a good role in managing a patient with functional dyspepsia, sir.
Okay. Thank you, Dr. Arun. Let me check any other questions. And Dr. Kannan has congratulated you for having a very good session. So that is encouraging.
Thank you, Dr. Kannan.
So I think if there are no further questions, we can wind up the session. Thank you, Dr. Arun, for even I too learned many new things from this presentation. So it's very useful one. Keep doing more and more presentations like this, and I'll be very happy to part of it. So thank you for the organizers.
Thank you, sir. Without you, thank you, sir. And without you, this session won't be a complete one. And we are all very proud that you are a leading gastroenterologist in Madurai. And moreover, you are doing more endoscopic innovations and interventions. And recently, I have seen your presentation of slide like endoscopy sister gastrostomy being tried for a patient with necrotizing pancreatitis, and even necrosectomy has been done. So I would like to congratulate you, sir, in a censure as early within a short period of time. You are establishing yourself, and it's really a great pleasure for us to be along with you also. Thank you, sir.
Good.
Also, I would like to thank all the participants who have been involved, and also I would like to thank Sun Pharma to give me an opportunity to participate.
Thank you very much, sir, for sharing your views on GRD. It's in fact, in-depth illustration on both diagnostic as well as treatment options. So I request you to continue to be a partner with us for programs. We'll continue to have such programs in future as well. And it's an opportunity for us to thank all the guests who participated. I hope it must be useful to all of you on a daily basis. And thanks a lot. And I just take the opportunity to remind just two of our brands. One is our Pantocid, 80 milligram, the first ever DCGA approved pantoprazole 80 milligram with a dual release gastro-resistant technology. And followed by we have Pantocid DSR, pantoprazole in combination with time-tested domperidone. So it's Pantocid DSR, both Pantocid 80 are freely available in the market. I request every one of you to utilize the opportunity. Thank you very much, sir. Once again, all of you. Thanks.
Thank you all once again.